Hi, everybody. Big hugs. We miss you so much. I'm so happy to see your faces. We're really grateful to our sponsors this evening. Takeda, Novo, Diplomat, which is becoming Optum Infusion Pharmacy, and Medexus Pharma. I want to shout out a big thank you to our tech team, Chris Brewer, Eric Lowe, and Joan, who has a better handle on this than I do. So I cannot thank you enough for being able to make all of this happen for us. Again, a big thank you to our physicians, and I'm going to introduce them in a couple of minutes. And a big thank you to all of you for being here on a Thursday night or Thursday afternoon, wherever you're from. Thank you so much. We just love to see your faces. It's just awesome. Just a reminder, next Thursday on October 22nd, we will be welcoming Dr. Christina Haley and her OBGYN, Dr. Maureen Baldwin, for a session on managing menorrhagia. For everyone that's interested in coming. One of the blessings in one way about having you do this virtually is, we'd have an OBGYN with us at LadyBugs, and we'd have an hour and a half, and we could have spoken to her all day, right? And bless her, she was trying to cover from, beginning of menses to menopause within that 90 minutes. And it just, every evaluation always said, we need more time. We need more time. And I'm like, I know you need more time. So in this way, by doing it virtually, we decided to kind of split it up. So we will do Managing Menorrhagia October 22nd. And then in January, we will be continuing our LadyBugs programming as well as our rare bleeding disorder programming. And we will do another session on childbirth and birth plans for women with bleeding disorders. And then we will also have another session on sexual health and intimacy issues, which is always something that, we've tried to touch on it, and a lot of the comments were, we'd like a little bit more information on that, and I totally get it. So we're really excited that we'll be able to offer those kind of in their own 90-minute session. So Dr. Haley and Dr. Baldwin are from OHSU, which does have a women's clinic, so we're really excited to have them. Once we split into our rooms, if you put your questions in the chat, the person who's moderating the room will keep track of them. To be mindful of our speakers' time, we're going to save the questions till the end. I know everyone has a question, and we just want to make certain that our speakers who have put a lot of time and energy into their presentations have an opportunity to get through them all. And we will try to answer as many questions as possible, but please note, the moderator will be taking probably the questions that are the most pressing from the largest group of people, and we're just going to do the best that we can.
All right, let's go ahead and get started. So the topic obviously is in women and girls with hemophilia, and this is normally we have these presentations a little bit spread out amongst the programs, but it is very similar to the one I recently gave. But none of these meetings were supposed to happen like within a week of each other. But I did include a little bit more information at the end. And so these are the disclosures. I'll leave it on here for a few minutes. And for those of you that didn't see my previous presentation, there actually is, and the link is on there. If you look at the link on the bottom there, and I think it's on another slide as well, but there actually is a hemophilia carrier manga or whatever it's called, graphic novel that's available that a Japanese physician and their daughter is a carrier. So it's interesting, worth checking out. So I just took some pictures from it, included it just because I thought it was kind of interesting. And so I think the girl's name is Kahoro, I think, if it's correct. And so, one of the questions, just like she has, is what kind of bleeding issues should we expect? What kind of data there is? And there's a little bit more from last year, not a ton more. We attempted to do a bunch of different types of studies, and obviously in the last 9 months we've been a little distracted with COVID as well. But if you look at the CDC data, this is all women with bleeding disorders. And by far, and there are two different ones, there's some in the registry and some in the population profile. And you can see, when you look at just hemophilia, it's not the largest part of the pie. Severe platelet disorders and von Willebrand's make up the biggest part. And then, and hemophilia just edges out rare factor deficiencies. And there's a wide variety that are included in that. So that's why that's a bigger group. If you drill down a little bit more, this is from earlier this year, there's probably about 600 or so hemophilia A carriers in the ATHEN data set, or American Thrombosis Hemostasis Network, and about 230 or so hemophilia B carriers. The majority that are in there are mild or moderate. And so that's really where a lot of the focus, and I think that's where the research should sort of move toward, because that's sort of where we could, actually probably do the best in this situation. So you can see here's the breakdown. You can see by far mild disease is the most common in the carriers, followed by normal levels. And I think that's common, and it gives you a nice normal distribution curve. I think that's what's more typical of what you would see. And, there's another thing on here. So I know you'll have to talk to the host on here if you're in the wrong room. I have no control of that. Sorry. I see a lot of comments about which room you're in. So, yeah. You'll have to reach out to the host on the chat. But, the first really big study came in 2006. And it was by Dr. Plug. And what you could see here is the average level is about 60%, which on average it's somewhere between 40 to 60%. But you have levels as low as single digits and ones that are high in the 200%. And of course, if you have high normal levels, there's much less likelihood to bleed. And typically bleeding is significantly lower once the level goes above 60%. And there really isn't a lot of other medications we're going to do just because the risk of blood clots would go up. And so most of the focus has been on the less than 60% or around that level, particularly if it's at a baseline. And when you look at data on here, when you just talk about bleeding, it's about 2.2 times more. Sorry, there's lots of notifications popping up on my thing here. About 2.3 times more likely to have dental extraction bleeding, and 23 times more likely to require some intervention. And of course, there's people that keep bouncing in and out of the rooms. And then there's about 2.6 times more likely to bleed after surgery. And so, sorry, it's hard to advance because there's always people coming in and out of the room. Been getting a lot of notifications, sorry. One of the more interesting things that we've been trying to figure out is that we know that hemophilia carriers, factor VIII and factor IX, really aren't good predictors of bleeding. And this paper demonstrated this. It was a lot of carriers and a reasonable number of controls. Most of the women were in their upper 40s to 50s, largely Caucasian population. Most of these studies are done from Europe, and most of them were of severe type. And the bleeding scores were but there really wasn't a good correlation, meaning that some carriers with levels of 30% may bleed less than those that have levels of 60%. And we know that carriers have increased relevant bleeding. This is a paper that we published with Dr. Porosky Wheeler, who's now, sorry, I keep getting notifications, and Vanderbilt. And if you look at here, the bleeding score here, the average bleeding score, if you look at the gray bar on the left side, was about 5. And for the normal women, it was about 1. And then if you look at the menstrual bleeding, which is on the right side, the bleeding score, the higher meaning worse, more menstrual bleeding. And when you look at the controls, their scores were actually pretty high. They weren't normal. the great thing was about this is that it wasn't just our data that demonstrated this. Paula James, who's a great provider in Canada, had almost similar data. And Peter Seigan at Penn State had almost identical data. And so it really lined up that they were having this bleeding. But remember, when we look at bleeding, some of these symptoms may have happened 10, 15 years ago. If you had a hematoma, you're 30 years old, and you had a bad hematoma when you're 18, that sticks with you on the score. So the problem with the score, it's not dynamic. And it certainly can't predict bleeding unless it's very high. And so what's the rationale for bleeding? Well, the only thing we were able to demonstrate was that if you're a carrier with hemophilia A, you carry that mutation, you have much less of an ability to elevate factor VIII immediately after DDAVP. And that's what the controls here on the right side did a much better job. They, on average, got over twofold. And carriers, on average, didn't change that much. And then at 4 hours, it almost actually went down compared to the normals. And so my theory back then was that that may be why it's the ability to elevate your levels in the setting of stress, and that predicts whether you're going to bleed or not. And I've seen this before because we've had patients that have had blood clots and they have von Willebrands, and if they come in and their levels are very high, I don't give them factor. I wait for the levels to become reduced and start to move down, and then I give factor to replace it. And that's worked out pretty well. And so I think that probably applies as well for carriers. The problem with VWF is that the ones that have a great response are probably not going to bleed that much. But if you have a crappy stress response, that means you're probably going to be more likely to bleed because your body can't get the factor levels up and protect you. This is Peter Seigan. I just like to feature other providers that are working in this field. He's a pretty young investigator. Kind of looks like the guy from New Girl, if you know that TV show. I've told him that lots of times. I think he gets tired of that, hearing that. But either way, he's working on this study, and I'm going to hopefully be helping him out. So it's nice to see other people in this. He is trying to get funding from the government to fund his training, and he's at Hershey Children's Hospital, or Hershey Medical Center, which is associated with Children's and with the adult hospital. And he's hoping to use a lot of different characteristics, particularly something called the X-linked chromosome inactivation assay, which isn't a commercial assay. But what it does is it tells you how much of your factor VIII being low is from dad and how much of it's from mom. And that makes difference. So let's say if your mom is the carrier and you got it from her, if you express a lot of her factor VIII, then you're going to have low levels. But if you express a lot of dad's factor VIII, your levels are going to be normal. And vice versa, if your dad is a hemophiliac and you're an obligate carrier. And so that we really think that assay is going to really help us predict bleeding. Early data showed that it's very useful, but we need to do a big model, and hopefully he gets funding. We've already told him we would participate in this study. So stay tuned for next year. So let's do a case of B carrier. We do two different assays. So in hemophilia B, the chromogenic assay hasn't been particularly that much better. It can be a little bit better, but it really isn't particularly useful. There are in some males it can be useful. It isn't really helpful once your level's above like 10%, 15%. It really isn't very. You're not going to see a huge difference between the chromogenic 8 and the 9, and it's not even FDA approved in the U.S., so it's really hard to do that. So this carrier had gotten factor before tonsillectomy, had a bleeding score that was elevated, and then had joint bleeds, 3 over an 18-year period. So that's really hard to predict, hard to treat, hard to prevent. Are you going to get 15 years of factor to prevent one joint bleed? That's pretty tough. And so obviously it's more challenging than a lot of people think. It's just something simple, but it's not that simple. So how do we manage joint bleeds? Well, we know that it happens. This just shows that a woman has reported 1 joint bleed. In our study, most women reported 1 to 2 over a 40-year period. And so that's hard to justify prophylaxis for 2 joint bleeds over, that period of time. And so that's where it gets a little tough. And obviously it'd be good if we somehow could predict who's going to bleed and see if we can do something about it. So that's where it gets more challenging. And if you look at the study that we did years ago, sorry, the references got cut off because there's a lot of stuff on these slides. But if you look at the women that have normal levels, that's the dotted line, joints become reduced in their range of motion over time. If you have normal activity, it goes down. If you have mild, it goes down more. If you have moderate, it goes down more. And the reason we don't have a lot of data on severes is because these patients got HIV and hepatitis C just like their male counterparts in the 1980s. And so we don't have a lot of carriers in their 50s to 70s to report data on, at least in the CDC study at the time. We did another chart review. We attempted to do other kinds of studies and were unsuccessful. This is one that was successful. We presented this data, it probably seems like 100 years ago, but I think it was only 3 months ago. We presented this data at WFH, so we got 3 different institutions to review their data on joint bleeds and other bleeds. And since I'm talking about joint bleeds, I broke out the 9 joint bleeds that were reported in this cohort. And you can see here, sorry, I keep getting 1,000 notifications about people entering rooms here, and so it's making it hard to advance. So one person had right knee, another person had the left knee, 2 people had the left knee, another person had right ankle, there were 3 that had elbow, and then various other ones. And so joint bleeds do occur, and these were only in the factor VIII deficient carriers that we had. What about in the Athena project? So I heard that Christina Haley is going to present at some point. Well, she's one of my partners. She's leading this study. This is and Peter Coates is the mentor for us youngish folks, I guess. And you see the data on the carriers. We're collecting data on all women with bleeding disorders, but of course I'm reporting out only the carriers here. And so out of the 700 participants, 71 had reported a joint bleed, and the majority actually reported less than 3 joint bleeds their entire life. So I think that's important, sort of quantifying. And then here, 261 participants, 23 had joint bleeds. And you can see that's in contrast to von Willebrand's rare bleeding disorders and qualitative platelet disorders. And hemophilia A had the highest joint rate, which isn't surprising because of the nature of the stress, and it's more commonly reported on here. And we don't expect as much joint bleeds in von Willebrand's, particularly the ones with milder disease, which makes up most of the cohort. So what about joint bleeds? So that previous study I showed you was a Swedish study from 2006. This was a registry study. It's one of my colleagues, actually a few of them on here. Mehdi is the first author who sent me this paper to review. And Eric Berntorp is a provider in Sweden, in Malmö, Sweden. And so is Jan Ostermark, famous hemophilia providers. What they did is they got a cohort of their patients over 22 years. They got the patients out and they ended up with 50 carriers with less than 40% and 160 carriers, A and B, over 40%. You can see here, look at the distribution curve. Just like as expected, most patients live in this 40 to 50% range here. And that's what you typically see in almost every population. So what were the findings? Well, the carriers were 2 to 3 times more likely to have documented joint bleeding events and 10 times more likely to have joint surgeries. So if you have a level less than 40%, you definitely are at risk for joint bleeds, and this study was a really nice study to demonstrate that. So what do the guidelines say? Well, if your levels are, between, particularly if they're less than 40% and in some rare situations less than 50%, there are some things you can do. We don't have DDAVP because it's are recalled, and so we only have intravenous and sub-Q. But factor can be given, but it needs to be given at lower doses, particularly those that have mild disease, because you don't want to get the level so high that the woman is at risk for blood clots, particularly if they're on birth control pills, or if they have other risk factors like obesity or smoke cigarettes or such. So those kind of things are important that we don't overdose, because we certainly don't want to do that. One of the things I thought was interesting, so I went back to the Athens data set and I looked at this non-severe men, right? So we know that those are rare. We don't see a lot of severe women, but we do have a fair number of non-severe women. So half of the men in the cohort of hemophilia A are non-severe, and the data is listed here, and it's we have it by region, but I didn't have all that information on here. The most interesting thing is if you look at those with mild disease, on here, when you look at prophylaxis rates, by the age of 18, 1 in 10 mild boys with mild hemophilia A have been on prophylaxis. If you look at the moderates, 52%, so over half have been on prophylaxis. And so I think there is definitely a role to consider, particularly if their levels are less than 20 to 25%, and they have had recurrent joint bleeds. It should be something considered if you've demonstrated that those are truly joint bleeds. So what are the implications? It's really important to ask for joint range of motion to be done every 2 to 3 years, to document this, to see if there's a change. You can do plain films on the ankles and knees and do a Pedersen score. I think carriers that have levels less than 40%, I think are at risk for joint bleeds based on the data that we have. And so I think it's important for us to see this. And so I see one of the questions, well, the mild boys, the ones that were typically on prophylaxis are typically levels less than 20%. So they're the ones that are like 6 to 20%. Most of the time in our center, it's because they've had joint bleeds, or they presented later, or they had some devastating bleeding event, and we ended up trying to do that afterwards. And so, is there an intervention? Well, it's not really clear where prophy can prevent this. We really have to do studies. Remember, in this country, most men were not on prophylaxis until after now, if you looked at data from 1994, and it wasn't until Marilyn Manco Johnson's definitive study showing a benefit from the joint outcome study in which the prophy rates went up. And so we need some similar study, and it's going to be very difficult to do, I can tell you. And so it's going to take some really clever study design, because if you're only having 1 or 2 joint bleeds over 5 to 10 years, you're not going to be able to do that in a study. It's just not going to work. And so what I think may be helpful is to do a study in which they're non-severe Hem A patients and non-severe Hem B, and you allow men and women to enroll in the study if they have certain bleeding events, and do a prophylaxis study. And this is what I've proposed to multiple companies. Hopefully, eventually, they'll bite on the idea. So let's move to the second case. So we're going to talk about heavy periods. So chromogenic in hemophilia A carriers may particularly be helpful. It can be lower depending on the mutation type, but it also could be higher depending on the mutation type. And there have been cases of this depending on the mutation that you have. And this is Kaharo asking the same question. Is there a relationship between heavy periods and being a carrier? If you're a teenage girl, 40% of them have heavy periods. So it's not like it's not a common problem. It's a really common problem. We did a study of adolescent girls in the Atlanta area, and we had over 200 girls come to our emergency room in 2 years. About 10% had von Willebrand disease or mild von Willebrand disease, but the rest did not. And actually, the ones that end up having the worst admissions were not the ones that had bleeding disorders. So you always have to remember what's on the other side and not just what's happening on the bleeding disorder side. So this person failed a bunch of different therapies. We tried agestin, it didn't work. We tried combined oral contraceptives, and that didn't work as well. So at this point, then there's a reason to consider, factor therapy, particularly since the levels are less than 30%, because it's very difficult to get insurance approval. Remember, these products are quite expensive, and there's not a lot of data. So that's what the insurance companies would like to see data, and that's why we need to do studies to do this. And they've been very difficult to do, and I've struggled to complete that study. And so when you look at menstrual bleeding rates, they're near 70% in carriers and about 40% of normal women. So it's very common in normal women as well. This is what the endometrial lining looks like. So there are times when hormones are the optimal strategy, because progestin helps increases the blood vessels in this, and it becomes very disorganized, particularly in those that have anovulatory bleeding early on. And factor alone is not going to fix it. We know that estrogen can help it. In our study in adolescent girls, when they came in with atrocious bleeding and had hemoglobins less than 7, on average, the estrogen stopped the bleeding almost completely within 24 hours. And factor would not do that. When your endometrium looks like this, it's going to take some time before it would be potentially useful. Maybe in the next 2 or 3 cycles, it may be useful. When we look at what's been done, birth control pills are the most common. And you have to remember, people are using it for more than one reason. When I see 20-year-old girls, they may be using it for birth control, and they also are gaining the benefit of menstrual bleeding control. And so you can see the data here on the Athens data set. Sorry, it shifted a little bit. But desmopressin, which we can't really use right now, is available, and Amicar. And then rarely we are using von Willebrand concentrates, and we're trying to characterize this in another study called the Athens 9 study that I think Peter probably will talk about. We're halfway enrolled, and we already have 10 women that are enrolled with von Willebrands that are using it for their periods. So I'm hoping we get about 30 or 40 in the study, and then we'll be able, that will almost double what's been published. So if you look at this in hemophilia A carriers, we actually had 2 highlighted here that used factor to control bleeds, but it wasn't that great. The control was okay. And so clearly we have to figure out, it's not just, one or the other. Sometimes it's more than one at a time. And so that's why we need to sort of figure this out, and it's going to take studies. And obviously there are multiple options that you can use to treat, and they're listed here: tranexamic acid, birth control pills, and factor replacement. And we have to be careful when we use them together because of the thrombosis risk. It is a real risk, and we need to be mindful of it, because you can imagine if you developed a blood clot, we'd have to put you on blood thinners, and then it's going to get more complicated. So this is Kaharu experiencing, one of the terrible periods that some of the girls can have. And for heavy menstrual bleeding, we know it's not really clear whether Prophy works. We tried to do a study, and we couldn't get good enrollment for it. Trying to design the right study is very difficult, and it's going to have to focus on other outcomes, not just it's going to have to be quality of life outcomes in addition to other things, or it's just not going to work. And the best plan for now is to consider hormonal therapies up front. IUDs have worked. We have carriers with levels of 2 to 3%, and the only thing that worked well was an intrauterine device. And so just something to think about. You had some other patients that use factor, and that works. And so sometimes you have to try different things. There are no current studies right now that are open for this, but we're hoping eventually we'll be able to get some other national studies, because often they're all from single institutions, and so we can't really do these. And so the final case is a B carrier that now wants to have family. You can see her bleeding symptoms there. Her factor 9 level is just in the very mildly reduced. And so she kind of want to know what needs to happen. If you look in this data set, we had about 1 in 3 women had postpartum hemorrhage, and that's about 1 in 10 in normal women. And we know that there are different ways to deliver, and this is a very difficult decision to make. If you had a child that had an intracranial hemorrhage, I think you should certainly deliver via C-section. If you're in the right hospital and they're able to convert quickly to a C-section, not wait until the last minute, that's when the problems happen, because then they have to push the baby back in. They may have used assist devices, and that's where the problems happen. Because if you look at the data, there are patients that have intracranial hemorrhages that had C-section. It's because those were like vaginal deliveries that did not go well, and then they ended up being C-sections. And so these are really good papers that discuss the differences. Dr. Leung, one of the many Swedish doctors, they have about 5 of them there. They take care of about 400 patients, but they have about 10 hemophilia and von Willebrand docs there. And, it's really important to have this discussion, because it's important to understand your options. When you look at A carriers, the levels can go up 2 to 3-fold. The B carriers, it typically doesn't increase that much. There are some mutations that it may go up. And people always tell me, well, their level went up. Well, I would like to see consistent lab values, and you always want to make sure one of them isn't an error in lab, which happens. And I could show you some slides later that will talk about that. But these are the data summarizing. Mine was the Porosky et al. She was my young investigator. And so, it's probably somewhere between 15 to 20% is somewhere where the truth lies. So what about peripartum care? You should give DDAVP for procedures. something to be considered, but also to acknowledge that a lot of fluids are used, and you have to be mindful of the fluid restriction. You can give IV DDAVP, so that's still available. And there's very little data on how, supportive this. What about factor use? Factor use has been used in the peripartum period, has mixed results, but definitely worthwhile considering with antifibrinolytics, and we've done that before. Antifibrinolytics, it probably works well with carriers if their levels are low, particularly if they're less than 100 at the time of delivery, should be considered liberal use of antifibrinolytics. And that's what the guidelines sort of say. If your levels are 30 to 60%, you could give a small dose of factor, and that may be all that's needed, or you could give it with tranexamic acid, and that could be a particularly helpful, for that. So, and so we know that there are a lot of risk factors for postpartum hemorrhage. If you talk to GYNs, many of them feel that the data that showed the worst rates are from countries that are not aggressive at trying to stop the bleeding. And so lots of antifibrinolytics make sense. Some use of factor, 1 dose probably is more than adequate, potentially 2. And then really if you're having like a epidural, you need to be getting levels and maintaining the level above 50% and avoiding assist devices and making sure the levels stay around above 50% if there was a C-section or a particularly difficult delivery. And so what about lab evaluation? So when should you send it? It should be sent prior to the first period. We get referrals all the time for people that want to have carriers tested when they're like 2 months old. It's very difficult to get blood on a 2-month-old, as everybody knows. And it's not really necessary to do it unless that 2-month-old has bleeding symptoms or if they're having a procedure coming up. Sorry, I get notifications on here and it's hard to clear it. So we know that in carriers, 1 stage works really well for Hem B, and then 1 stage in chromogenic for hemophilia A. And it should be checked every few years just to kind of get a trend. And we shouldn't focus on the one level that might be a lot lower, thinking that that's the real one. It should be on the trend of the levels. If you have levels that are consistently 40 to 60% and you get one that's 20, that 20 probably isn't real. And then the genetic testing needs to be sent sometime in the teenage years, and then consider treatment if levels are less than 60%. So when we see a patient for a bleeding workup, these are the labs that are typically sent. We send a CBC, we send coags, we send fibrinogen, thrombin time, and then we send platelet testing. And then we often work patients up with von Willebrands. And it's important to understand we do have some carriers that have low VWF. They may say they have von Willebrands, but they probably have more of what's called low VWF. And this is the coagulation cascade that shows, the factors and where they are and where the times are on here. And remember, when we do these factor assays, we're not really measuring the factor level. We're measuring it on a curve, and we're assuming that it's relatively similar to that curve. And so we often can send, if you have a prolonged PTT, we can send other levels. If you have a prolonged PT, we would send a 7. But remember, most of you on this call, if your level is above 35%, your coags are going to be normal. And so it's important that you do the factor test, not just the PT and PTT. And if it's prolonged for both of them, then you should consider other factors. And then things like factor 13, sorry, got a little bit shifted on here. And then, platelet aggregation studies, for the other regimen. I'll mention that in here just because I was asked to present some of the labs. And so this is an example of what a PT is. When we get a PT and we do a factor 7, this is what we do. We get your blood in a blue top tube. It's platelet poor plasma, so it's been double spun. It has to be processed well, and it has to be processed really within an hour. And it either has to be performed or frozen. And I saw last week alone, 3 patients with low factor 8 levels. And it was probably because they had really bad lab levels. And when we checked the levels at our institution, they were just completely normal. And so factor 8 can be falsely low if this process isn't done correctly. And so that's the PT. This is the PTT. The same thing happens, light blue top tube. You have to fill the tube all the way up. and then we look at the time it takes to form a clot. Oftentimes, if the reagents are changed often, if it's not stored properly, if it's not completely filled, you get abnormal results. And if the patient is really anemic, sometimes you can get abnormal results as well, because that can definitely cause problems. And we see this all the time. I get referrals all the time for a kid that's going to have his tonsils out, and he's got really abnormal prolonged PTT, but usually that's just because of some non-specific inhibitor that just goes away because they have an infection. And this is an example. On the left side, you have to put this ratio of plasma to citrate, and it really has to be a certain amount of ratio of 5:1. And if somebody has a high hemoglobin because they have some cardiac problem, or if you don't fill the tube up, you're going to get wrong results. Although it's extremely uncommon, this is the way that we perform Bethesda assay that measures inhibitors, because I know a number of you have children and you may or may not have people that have that. And the comment on here about a normal PTT is not meant to screen for factor VIII deficiency. So you can have a level as low as 30% and have a normal PTT and it means nothing. And you can have an abnormal PTT and a normal factor VIII and that means nothing. And so it only matters what the factor levels are consistently repeated. And so when you look at this, when we do inhibitor testing, we dilute it out until we inhibit factor VIII by 50%. And that reciprocal of that dilution is what it is. So 1 in 5 means you have a Bethesda inhibitor titer of 5. It's very rare that women have inhibitors unless you have Turner syndrome. Outside of that, it's exceedingly rare, and it's not something that we routinely send because it's just almost never occurs. This is what the platelet function looks like when you do this. It's basically the time to close off a glass tube. Sometimes we'll check the platelet function of a woman that has extra bleeding symptoms to make sure there's not anything else. And then we may do platelet aggregation studies. And what we're looking for is when you add something to your platelet-rich plasma, we want to see whether it's going to clot appropriately. And that's what happens. So that's one version, and you can see what happens to the platelets over time. And then we have something called whole impedance aggregometry. And so there's 2 electrodes. We add the agonist, and we want to see whether there's platelet aggregation, and that will inhibit the amount of energy transmitted. And you get this readout, and it's measured in ohms, if you remember from science class. And so that's what you see. The platelets aggregate on the electrodes, and that means that your platelets are working well. But when they don't, that means you're going to have low impedance. If the impedance is high, that means your platelets are working just fine. So what needs to be done? So sometimes I feel like Kaharu here, I get tired like everybody else of trying to wait to do the perfect study to answer these questions. But I think a registry needs to be done. It needs to be done outside of CDC. Probably needs to be run, maybe funding from either some industry or some kind of foundation. The study like this, that has hundreds of patients would probably cost upwards of $500,000 to $1.5 million to run. I think bleeding scores should be done, joint range of motion, X-linked activation studies, a variety of things that needs to be done. There are other studies like Athens 7 and Athena. So if you're enrolled in Athens, please participate in the Athena study because we have gotten some data out from that. And then the Athens 7 study is also looking for men and women with factor VIII or factor IX deficiency. So you have to have a deficiency and to participate in that study. And we need better data to learn about this. We don't have a lot of data in the older women, and so we obviously need data that goes more than 5 to 10 years. So I think that's going to be really important. And then we really need to create a network that focuses on bleeding symptoms. Studies have to be designed, focused on those symptoms because they're really hard to do if you just do them separately. So that's the end of the presentation. Thank you very much. I think we have maybe a 15-20 minute Q&A session. And so, I think we can talk about this. So,
a couple of questions from a little ways up. One of the questions was, what's the best way to find a study for maybe some of these
Yeah, I mean, so right now, if your site is a participant in the Athens studies, then you should ask them, do I qualify for the Athens 7 study? So it's the 7th study. Or do I qualify are you participating in the Athena study? The reason we call Athena because it's the goddess of war. So Athens, it's a kind of a play on words. I think Peter came up with that. So I always tell them, if you have to explain the joke, I don't know how funny it really is, but that's a study that's focused only on women. By the end of the year, we're done with that study. It doesn't provide any testing, but we get more data on you, so then we can report on this. And we're just short of 300 women with bleeding disorders, and we really would like to get to 300 by the end of the year. So I think that's going to be particularly helpful. Those are the kind of studies that are, it's a pretty inexpensive study. We just report out data. We do bleeding scores. We do a couple different things, and it just helps us characterize it and report it out to the public. So
awesome.
The only other study, sorry, I forgot to mention this. The only other study that allows women into it, the Haven 6 study, which is sponsored by Genentech, which is looking at emicizumab in mild and moderate hemophilia A, and it's only available to men and women with levels. They have to be less than 40%. And there are a few sites that are going to enroll women. I anticipate about 5 to 10 women being enrolled in that study. So, but it's going to probably close in the next 2 months, to be honest.
Okay. Another question I saw was, you may have covered it during your presentation, but real quick, what are the next steps if factor VIII levels don't reflect heavy bleeding or joint issues?
Okay.
Or are there other tests that will reveal more?
Yeah, I mean, that's why I listed the other labs. It's pretty common to see low von Willebrand factor, in addition to being a carrier, particularly if you have blood type O. And so there's probably other genetic reasons. We're trying to do, Hemophilia Georgia sponsoring a study in which we're going to look at low VWF and try to better characterize that. But that may help us explain why there may be some more bleeding symptoms. I think it's going to be more complicated than you're just a carrier. It's going to be more than that. There's going to be a variety of things that we don't know, but we're hoping to figure that out. And that's going to be the future, is all this genetic testing. And so we're going to do this in all our low VWF patients. And eventually I'm hoping that we can extend this to the carriers in our institution as well, because it'll be helpful to get that information.
Would you say that, like, kind of going forward, that just applying the label of mild, moderate, severe, and maybe like some kind of factor level, that's not even in some cases is applicable to, it's not very revealing? Is that, I mean, I'm guessing that's what you're saying with as genetic testing.
Well, I mean,
forward.
most of the carriers have mild deficiency.
Mm-hmm.
And so most of them fit in the same category, but mild is a big category. It's as low as 6% and it's as high as 50%. And there are definitely differences. Once you get into less than 10% and you're a carrier, you're going to have pretty significant bleeding events. You're at risk for spontaneous bleeds. And when you get higher, you may have bleeding symptoms, but it's not going to be the same as somebody that has 5 to 6%. Mm-hmm. And so that's why I think, it's important, because that mild category is really big. And so it's important to do other testing, looking at platelet function, and considering, von Willebrand factor to see if it's low, and it may be low because you're a blood type O, for example, which is, a very common blood type.
Mm-hmm.
Let me see. Let me get past. I can see the questions here. How do you know if you have mild hemophilia? Well, I mean, it's not complicated. If you send factor levels on multiple occasions and they're within 6 to 50%, then you have mild deficiency. It's really that simple. It's not complicated. And so that's where, it's important that those labs are done, and it takes some time to do. And, it needs to be repeated on a couple of occasions, particularly factor VIII, because it's a very fickle factor and it can really give you falsely low results. I mean, I really want to stress this. I see referrals all the time for patients with low factor VIII, and they're not because they're carriers, but because somebody worked them up for nosebleeds. And that just tells you, and then I looked where the lab was done. It was done in Columbus, Georgia, but it was sent to Salt Lake City because that's where the contract is. And so that can often give you falsely low results. Let me see. Let me get past all the ones where I said I'm in the wrong room. I know a few women that have normal PTs but low factor VIII. Yeah. So PTTs at most labs are set that it doesn't get triggered until it drops below 35 to 40%. And so some places like ours, it can be 30% and you have a totally normal PTT. And if you go across the street to Emory University, it picks it up a little bit easier. And so that's why the PTT, you can't screen carriers for that. It's a useless test by itself. The only thing that matters is the factor 8 or the factor 9 level. It talks about anemia in here. Yeah, that's common in carriers. That's common in women in general with bleeding disorders. And so that's a universal thing that everybody shares. And, I think, it might be worth discussing maybe in a future session to have somebody talk about IV iron because there's probably some benefits to that. The next question is, having type 1 von Willebrand's and also blood type O. When is it? When would you test somebody that has von Willebrand's? And maybe someone's in the wrong session. It's okay. So for von Willebrand's, if you have severe disease, it should be tested relatively early because if you have severe disease, it's going to be low. If there's any procedures, if there's any bleeding, you certainly should do it. If you're thinking of doing circumcision, if it's a boy, then you should test it. But it definitely should be repeated after the 4 to 6 month period because it may be elevated because of the stress of delivery. And that can last a few days. If you have severe disease, it doesn't matter if you have blood type O. Blood type O is only important if you have mild disease. If you're severe, and it doesn't matter what blood type you have. Someone was asking about doctors in California that treat women. The best place to go for this, let me just type it in here, is go to this website, and if you go look at the treatment centers on there, it actually will let you know what centers have what resources and what their clinic is like. So go on that website and take a look. I certainly don't know all the doctors in California, and that's a big state. So you obviously want to find the one that's closest to you, of course. But there are some that have more services than others. But there's people like Diane Nugent, who's fantastic. But she's in Orange County, and if you don't live there, then it's going to be a long drive. Let me see here. I've had my levels tested after my son was born, a few weeks after that, and they told them they were below 80%, but they may be higher because of pregnancy. So yeah, it may be elevated post-pregnancy, maybe while you're breastfeeding, if there's a lot of stress on the body, and of course there is 2 weeks after your delivery. And so it would be worth repeating. The good thing is if your levels are that high, then that should help you protect you from some bleeding. And your body's it's good because your body's trying to protect you from postpartum bleeding. And so that's a good thing. But usually within like 4 to 6 months, that's probably about the time to retest. Someone was asking about muscles. I think that's always where it's hard. If your institution has musculoskeletal ultrasound, which a lot of the adult sides do, less of the pediatrics, it may be worth going to those places and look at those resources to see, is that related somehow to bleed, or is it just overuse and unrelated, generally to hemophilia? Because it certainly can be an issue because if you have low levels, you may not want to take things like Advil and other medicines, which may put you at more risk for bleeding. But certainly I have not seen issues with people that have very mild disease or less, have any issues with soft massage. And you can certainly use those muscle guns are popular now. And if you put on a low setting, that could help as well. And there's all those muscle rollers. If you've seen those are usually less than $10. They're little foam rollers that you can roll over the muscle that really help. I use that pretty routinely after playing tennis because they get pretty tight after that. So someone was asking about mild deficiency. So severe is less than 1%, moderate is 1 to 5, and mild is greater than 5, also known as 6%, up to 50%. Most of the cutoffs typically are around 40% though, but somewhere between 6 to 50%. Somebody's asking a blood type O. It probably does play a role if you're a hemophilia A carrier. It plays no role if you're a hemophilia B carrier. and it may make your levels a little bit lower, and maybe your levels don't go as high. There's a couple of the same questions. If your levels are 50% or above and you've had joint bleeds, well, I mean, one of the things, you've probably only had the one-stage assay sent. So somebody says, send a factor 8 or send a factor 9. What they're sending is the one-stage assay, and you should consider potentially the chromogenic assay could be lower, and it's worth sending because that may actually explain why the bleeding is there. And again, like I mentioned before, looking at whether your von Willebrand factor is low and potentially looking at whether your platelet function is normal as well. Everybody thinks there's only one thing that can happen, and that's what textbooks always teach us, but patients have multiple different disorders, and we've seen this in patients, and so it's important to understand that. So some people have inherited clotting disorders, and that may actually protect you from bleeding as well. Someone was asking about teething. Well, I mean, any kind of stress, anything like that could elevate levels. Certainly levels in a newborn baby. Factor 8 is going to be elevated for, potentially up to, but if the levels are low, like less than 10%, it's not going to be that much more elevated from stress. And once it goes below 5%, stress does very little to the factor levels. But it can if you're in the mild range. And so it's important to repeat those levels, 4 to 6 months later.
I have a question about hormone levels, and we might not know about this, but I'm curious if it's going to be involved in research. Because I know that for me, I can tell when my levels fluctuate based on my cycle, like you said, with breastfeeding when you're pregnant. Is that going to be involved in research, or do we know much about how it varies?
Yeah, so for a long time for von Willebrand disease, people made a big deal about checking your von Willebrand factor and your factor late during the cycle. But then there were a bunch of other studies after that showed absolutely no pattern. It was up and down, and it was up and down for the stress. Like if the woman is cramping a lot and it's painful, it's going to be elevated, right? I mean, so it's more complicated than that. There probably are some differences if you're on the borderline. There may be some differences, but that study would be really hard to do, and there have been a few of them done. But you probably have to have a lot of women, and then all those women would have to be stuck every day, potentially twice a day, for multiple cycles. And so that's a study that's really hard to do. I think there probably is a slight fluctuation, and certainly if we are giving high dose estrogen, your levels are going to go up. So if you're giving the equivalent of like 2 birth control pills, your levels will go up. 1 birth control, low dose birth control pill, it's probably not going to swing that much up. But for example, like we saw a girl with severe von Willebrands in the emergency room. Her baseline level for factor 8 was 5%. When she was in the emergency room, it was 30% when we diagnosed her. So we thought her levels were going to be higher. And then I checked it 4 to 6 months later. Once everything was under control, she was on a daily birth control pill. Once we checked it twice, then her levels were closer to 5%. And her von Willebrand factor was not measurable when we came back, but when she was in the emergency room, it was 30%. So it went up pretty significantly. And it varies between women for sure. So there can be stress on the body, not just hormones, but stress from like epinephrine or adrenaline. Like, for example, if I checked your levels now, and then I made you run down the street as hard as you could for 15 minutes, your levels will be much more elevated after that 15-minute run, potentially 2-fold higher. If your levels are 30% now, it could easily be 60 to 80% doing that. And that actually is something people should take advantage of. If you're doing activities, if you warm up, that actually may protect you from bleeding. So that may be something to think about. It's not going to last more than a day, but it certainly can protect you for the next 4 to 5 hours if you're doing aggressive. So warming up is probably helpful. So yeah, great question.
Fantastic. The only other was, do you know of any women with multiple bleeding disorders or families that carry more than one bleeding disorder? I know from our perspective, we're seeing a mix of a lot of different things. Seeing a factor 7 mixed with a von Willebrand. So we've seen it, but you've probably seen it even more as a physician.
Yeah, I mean, so think about things like so someone mentioned pain. Pain anything that puts stress on the body could do that. So can raise levels. And so, so factor 7 deficiency is pretty common. It's the most common rare bleeding disorder. It's pretty prevalent in certain groups. And so, we've seen different deficiencies. It's common to see low VWF with carrier status, hemophilia A and B. And so we do see some other factor deficiencies. It's typically like factor 7 deficiency. More than 2, that's unusual. Maybe if they met at bleeding disorder camp, maybe they did that. There are a few cases of hemophilia B and A carriers in women. That's pretty rare. That's definitely some mixing from camp. And but certainly von Willebrands and carriers, that's not uncommon. So
I think we've run into a 5 and a 7 before, which was they said it was a nightmare to treat.
Yeah, it definitely could be. Yeah, it becomes difficult trying to pick one treatment to treat both. It becomes difficult to manage for sure. And we still have limited knowledge on factor 7 deficiency. But there's a couple of providers like Dr. Nugent that's been doing a lot of genetic testing that should give us more answers in the next few years. Remember, for von Willebrand factor, it wasn't until the mid 80s before we knew anything real about the genetics of it. And it wasn't really until about 15 to 20 years ago before we were routinely getting genetic testing for hemophilia patients. And so we've really only sort of recently been able to describe and understand this, and it's only going to get better. We're doing this von Willebrand study, and we're going to be able to check for factor 8, 9, von Willebrand factor, Glanzmann's, all kinds of bleeding disorder patients for less than $300 in this one platform. It's a research study, so it's not but I'm just saying, obviously it's moved along. If I did that separately, it'd be about $5,000. So, a couple years ago.
All right. Well, I don't see any more questions. There's pops.
One more. After having a C-section, using progestin to help the period. So that can stabilize the endometrium. It's sort of like putting somebody in a pregnancy state, to be honest. And then factor schedule, and the periods were still bad. But just remember, if the endometrium is really irregular, it's going to take a while. Hormones aren't going to fix that dysregulated endometrium if the blood vessels are all crazy on there as well. So it's going to definitely potentially have some problems, and it's going to take time. And from our institution, it took on average 2 different medications, 2 to 3 different medication attempts before we found the right regimen for the woman with their heavy periods, regards to menstrual bleeding. So it takes time and trying a couple of different things, unfortunately. So it just have to be a little patient and try to figure it out. And so, because it is challenging, I know, and I wish we could figure it out. But there's, some things work for some women and some don't for others. And it's really hard to tell. So, so one of the questions about hemochromatosis is pretty common in Caucasians. There's probably more than one person on this call that has hereditary hemochromatosis. And so it can happen. I don't know if there's any connection to it. It really shouldn't affect your ability to bleed if you have mild cases of it. It obviously becomes more challenging with regards to iron deposition. You have to be a little bit careful about giving iron infusions and iron replacement, and probably need to be a little bit better about limiting bleeding so you don't have to replace the iron or replace with blood. So.
Fantastic. Well, this has been a blast. I've definitely learned a ton too. Even being a hemo A myself, always something to learn. So with that, I'm going to say thank you. I'm going to give you a little round here.
Thanks, everybody.
Everybody give them a wave. And I think we're good here. If you guys want to hop off, go ahead. I think I can just close this room and hopefully not close out the other rooms. But yeah, thank you all. And we'll see you at the next meeting.
Yep. Thanks, everybody. Hopefully see you in person soon. So
yes. Yeah, right.
Maybe next
that would be
summer.
Wonderful. Yes,
thank you, Dr. Sidonio.
Thanks, everybody.
Thank you.
Thanks.
Thank you.
Thanks.